Yeah. I'm here with Dr. Ziv Paz, and we're going to talk. He's the Director of Technology, and we're talking about how it is to be Director of Technology at a huge HMO, which basically serves 1/3 or more, about half of the population in Israel, has hospitals, has primary care, and has a lot of technology underneath. I hear that you were really involved with Harvard University. I mean, you're a medical doctor, you're an MBA, and you're very much involved with Harvard. So you basically combine a couple of worlds. What is your journey, how you got to this position, which I think you have for a year now?
Yes, indeed. So the journey was quite unpredictable in a way. When I went to medical school, I didn't plan or at least identify an objective to become the Director of Technologies of Clalit Health Services. I went to medical school, but from early stage I was interested in research. So I went to a MD PhD track, and I did another degree, a research degree in neurobiology and physiology. From that point, after you finish medical school, you do residency and training. During my residency in internal medicine, I felt that it's not enough. So I decided to leave, which is not traditional, but my path was not a traditional one, and moved to Boston to do postdoc in immunology and research. This is where I start. The first time I encountered the Harvard system, the Harvard education system, which was amazing. It started from a 1-year journey, but ended for a long period of 7 years.
Yeah, because I mean, you have also started. There's also Harvard here, right, in Israel.
There is not Harvard school in Israel. There is no Harvard school, but there's
a connection.
There is a connection. There are affiliation between many research institutions in Harvard in the U.S.
Yeah.
Many of Harvard graduates comes to Israel, and many of our researchers collaborate with researchers at Harvard institution. So it's really a great collaboration.
And when did this interest in technology and technology innovation came about?
So I always was interested in technologies. Innovation and data. It's already started for my army service, actually. I was a forecaster in the army, and I work with data, with predictive tools. So it was always something that I was interested in. This is why I pursue a research track throughout the way and conducted research and data research. So this was a great interest for me. And to practice medicine, but also to have the opportunity to lead change was always something that I was interested in.
Yeah. And now you're on top of the biggest healthcare organization, the second biggest integrated healthcare organization in the world, in Israel, a teeny little country. The first one is Kaiser Permanente. You said that 20 years ago, the company was very conservative, and that you only use proven technology. So there was a whole shift made in branding, in digital transformation, and also to be more forward-looking. How did that change come about?
So the country was never conservative. Our organization was more conservative. It's an old organization, it's an established organization. It provides health. You want to make sure that the patients are safe. You make sure that everything that you deliver is in high quality. So naturally, many health organizations, when they have the option, choose to be quite conservative. You do not want to make changes. Even during the training of nurses and physicians, they are trained to follow the protocol, to become very conservative. Yeah. So to move from that to become very innovative, a leader in new technologies, it's a great change for an organization.
Yeah.
And
so how did that happen?
So I think it's what's happening in Israel in general. The country itself it's like a hub of technology and innovation. So it's also influenced everything that it's inside this ecosystem. It's also our deep understanding that in order to excel and to be competitive next to our 3 other HMOs in Israel, we have to bring something different. We have to take advantage on our size, on our data, on our people, which are our biggest natural resource. And this was the key and the most important piece.
Yeah. Was the government also very pushy in that department? And does it come from the political point of view, or does it come from the experts or the bureaucrats?
So the government in Israel and Israel in general invests significant portion of GDP compared to its size in general in research and development. So the government has its innovation authority, the Ministry of Health has the innovation authority, and there are funds and grants that are given to develop and promote innovation, not only in health in general, but we are part of this large ecosystem. When you understand that you are not in silo, when you understand the mutual benefit of being part of an ecosystem, and you allow this kind of collaboration, this is the start to development and innovation and to become a real leader.
Okay, we the Dutch and the Israeli system are very much alike. You know, lots of GP systems, lots of attention for prevention, and also technology. But you have records, and you have the digital health records, and you can integrate them everywhere. Is your are you using mostly your own records, or are you integrating a lot with all the other HMOs and all the other care providers, or is it more your own internal system which you're using?
So our system is mainly internal system for our data usages, but you know it encompasses the data of 4.5 to 5 million people over a period of 25 years throughout the continuum of care. So it's enormous amount of data. This is first. Second, in Israel, we call it's called an Horizon platform. The Horizon platform, it's integrated national platform that integrate all the data from all the HMO. So every Israeli citizen that come to the clinic or come to an hospital, the physician can connect on demand to this specific platform and have the data regardless of the HMO of the patient.
Okay, so that's really flexible, open, and you can reach other HMOs data, and everybody can share it with each other.
So it's not so you know, it's a beautiful picture. I wish
that's a beautiful picture, but we want a little bit of reality.
A little bit of reality, indeed. It's a great question. So we can reach that at the point of care only. So we can reach our data all the time. Our HMO data, which is extensive, but at the point of care, we'll give you an example. When a patient from another HMO come to the emergency department of our for one of our hospital, when he approach and transfer his card, at the point of care, we can reach his data.
So the patient decides, the patient has a decision to make to present his card, and that gives also the access.
The access and authority, and also it's limited to the point of care. So right now I care for the patient, then I can access via the national platform, the Horizon, and see all the patient data. Everything is imaging, laboratory, everything, and all the summaries of his primary care physician visits and consultation that you've been to, and then
at the point of care,
after the visit is over, then this access become limited again. But again, I can access all the patient in my network all the time.
And is the privacy concern from the patient itself, the person, the citizen, or from the professionals, is privacy concern important, or is it a little bit less developed? Because we're a little crazy in the Netherlands about privacy.
Privacy is a key question. I think it was also a key question when we had a discussion with people from the Netherlands and other countries in Europe during the COVID-19. What you need to know, what is important to know, how you get this data about your patients. So we're also very serious about the privacy, but sometimes today you can use specific technologies, high-end, very expensive technologies that can help you to keep the privacy, but also to get the data when you need it. Technologies with the identification, technologies that can streamline exactly the data that is needed, and you have limited access to other part of the data. You have to work hard in order to create a balance between keeping the privacy but having enough information to make the right decision to the right patient at the point of care.
At the point of care. So, okay, let's talk last subject, COVID, okay? The whole world looked at Israel. I mean, we were constantly looking at Israel because you are 3 months ahead of us. What did COVID bring you? How did it change the system, and what will you keep of it after COVID is gone?
I think the COVID was a great opportunity. First of all, to use muscles that we had, but we didn't use them as often or to that extent. It also shed a light on what is happening in Israel. You know, the world before that didn't know about Clalit, and now we are approached extensively, but so many organizations, pharma and other companies that want to collaborate, because when you see this kind of data and you understand the strength of this kind of continuum data throughout significant amount of providers and networks, and throughout so many years, you understand the power of this data and the power that it can make or imply on patient and their health throughout the world.
Yeah, but did you, you described in your presentation the whole pyramids, and to go from data to how-to and to wisdom and the knowledge and wisdom. Did you go from data to wisdom in the COVID period?
So in specific aspect of our organization, definitely yes. So during the COVID-19, you wanted to identify patient at risk. Mm-hmm. So you need to develop algorithm. You want to use the data. So what kind of data to collect? Do we have it already in the system? Do we need to put sensors in place? And then we need to invest in data analysis and developing algorithms. So definitely we did that.
Yeah. And did that also lead to conclusions? Because, I mean, what we did, we closed down whole society, and then it did vaccinated, and we did booster and booster. Do you now have a more smart approach because of that data to for example, what we're going to have in the next 2 quarters with COVID?
So definitely, we already have predictive tools inside our electronic medical record to support a future decision in COVID-19, but also the tool that were developed and the approach and the strategy were already implemented right now in different fields. This is the real impact of COVID-19. First of all, the awareness and the readiness for a different, similar catastrophe in the future. But in addition to that, the technology and the effort that were already invested can now multiply in different arenas of the field. Mm-hmm. The data can democratize. The data now is more accessible. You want to have collaboration. You want to develop. We didn't develop all the algorithm only by ourselves. Yeah. So this is also became now part of our nature. And we are now.
So you're going higher up on the value chain and that kind of stuff. Last thing, telemedicine. Because you were forced to do telemedicine more. What is the state of telemedicine now in Israel at your organization?
Okay, so we started already with telemedicine prior to the COVID-19. Like many countries, and also the Netherlands, I saw that there was a significant effort in that regard. But the COVID-19 forced all health organizations to think again about how they deliver care. Mm-hmm. So definitely it promotes our telemedicine in so many arenas, in fields that you didn't even imagine that you can deliver care remotely.
What's an example?
So I will give you an example, for example, of ophthalmology, which is not a trivial field for telemedicine. But if you have the right sensor that can measure the pressure in the eye, in the patient home, you can deliver all the care if you follow patient with glaucoma remotely. Okay, cardiac care. If you have the right sensor that you can put, you can actually do complete cardiac rehabilitation when the patient is sitting in his living room.
And that is now massively used? I mean, hundreds of thousands of people are using that?
So it's a real change. It's a real change. And you change sometimes. It was a real need during the COVID-19. Everyone was pushed to do that. Yeah. As now we see some decline, but now we are doing it better. We know what works, what works less, and we do to some technologies re-implementation and scaling. Some telemedicine services we put aside. They were not effective. The patient complained. The technology is not well developed to do that. So it's a you did it extensively. You did it everywhere, and now
No, I can imagine. And then the last question also is, you're an HMO, you make new services like telemedicine. Are you free to then also put a payment on that for the service, for the healthcare providers? Are you the one who decides, or is the government also deciding what can you charge for what?
So we also, because we are the HMO and we are the insurer, we are not only the provider, so we have some internal discussion. So for example, for telemedicine visit, we gave the similar billing codes as for frontal visits. The same billing code as a frontal visit. And as an HMO, when one of our beneficiaries speak with his primary care physician in the office or via home, the primary care physician gets the same compensation, because you want to encourage. We can make that, but there are some services that you need the regulator, that the regulator actually help you to set up the prices and sometimes compensate you. So it depends. So there's different ways to work, and this is a more complex answer than I can give you like in 5 minutes. No, but in general, we have the benefit of being also the insurer of our beneficiaries. In many services we can do it internally.
You're an HMO, you have 50% of all the members. I mean, you're huge. You have hospitals, you are everything. Aren't you I would hesitate to say almost too big for for a center. Can the Ministry of Health deal with you because you're so powerful?
So we want to become bigger. You know that once we were close to 80% of the Israeli market. Before 1995, when there was a change in law, talking about government and regulation, we were close to 80% of the Israeli market. So now we are 50%. So we lost part of our market share. And by the way, competition is very good. So the fact that there is a competition and so competition, I think this is what also moves us from being old conservative organization to this cutie gentleman that you saw there. We need competition. Every organization needs competition. We want to be bigger, but we want to be bigger because the beneficiary choose us because we are great, we are innovative, we provide better care, high quality care, and we give them the care where and when they need it.
We'll see you in Amsterdam. Thank you very much for this conversation.